Brilliant. Well, we'll kick off then. Thank you very much for joining all. Excellent to host this webinar this morning on all you need to know about pressure care in seating with Joanne McConnell. So we'll kick off with just telling you a little bit about ourselves at Vivid Care and what we do, and then we'll move over to Joanne for the main presentation. And then we'll finish off with a practical session going through some of the features of the chairs in our video room. And then at the end, there'll be a Q&A section. So if anyone has any questions throughout the call today, please do put a note on the meeting chat and we'll cover those at the end. So please do ask away. Brilliant when we get some interaction. So just kick off with a little bit about ourselves, Vivid Care. So I'm speaking to you from our headquarters in Wetherby near Leeds in West Yorkshire. And we're a family business established in 1972. So been going a few years now. And we've been carrying out specialist seating assessments for over 30 years now. It's something that we're very passionate about. Because getting someone into a chair, getting them comfortable, getting them supported, and getting them safe with pressure care managed makes such a massive difference to people's lives. We often see it where we're out in the community or in hospitals, etc., and we see the joy and the difference it can make to someone's life, getting them out of bed into a chair, getting them interacting with their surroundings again. So specialist seating, we're really passionate about it, and we love to see that difference that it can make in people's lives, both for those who are sitting in the chairs, obviously, but also for carers, family members, and healthcare professionals. So all our chairs are made in Britain. We're very proud of that, and we're trusted by over 19,000 UK healthcare professionals, and we've got chairs in over 80% of NHS hospital trusts. But as well as that, we do a lot in the community, and we've got them in private homes all over the country. We also hire chairs, and we also have our own engineers, so we provide the full backup. And then we've also obviously got them in other care facilities like care homes and hospitals, etc. Really in every care environment. So our chairs are making a difference right across the UK, but also in every continent apart from Antarctica. So if if anyone knows anyone who needs a chair in Antarctica, please let us know. So we're part of a wider group called still family owned, but just mention there's a couple of other companies within the group as well if you want to look them up. In Overcare Concepts, who do a lot of the fitted equipment, so ceiling trap hoists, hydrotherapy pools, and other healthcare fit out environments. And then Aqueduct too. So Aqueduct more do the adaptations to private individuals' homes, like bathroom adaptations and wet rooms and stair lifts and ramp systems, just anything to help people stay in their own home for longer. So that's a little bit about us. And I think probably one of the key things that we're really bothered about in everything we do here at Vivid Care is about comfort, getting chairs comfortable for someone, getting people into a comfortable, safe position, and seeing the difference that can have on people's lives. So that's fed into everything we do, from the seating assessments right through to the research and development of our own range of Lento chairs. Comfort is really what we focus on. And of course, there's many different aspects, many different features that go into making a chair comfortable. One of which is posture. Another of which is pressure care. And pressure care is obviously the subject that we're focusing on today in this webinar. So without further ado, welcome Joe McConnell onto the call here today. So Joe's had many years of experience in posture and specialist seating, right from chairs through to wheelchairs. So over to you, Joe.
Okay.
Looking forward to what you've got for us today.
Yeah, thank you. Thanks for all signing up for this. I hope it's interesting. I know CPD time is precious, especially when we have to balance it against clinical time. So I hope you find it useful. I've set my timer because I can talk a lot. So just a brief overview of my background. So I qualified in '92. I've done a real wide range of jobs, and right through my career, I've always been passionate about posture and pressure care. Today, I work, part of my week, or a large proportion of my week is, as Tristan said, I'm a clinical team lead in a wheelchair service, and not there today. And then I work for myself 2 days a week doing a variety of complex postural assessments. I also work at a specialist college, some sessions for 19 to 25-year-olds, looking at all of their OT needs, including posture and pressure care. And then I really enjoy delivering educational sessions for a wide range of situations, and this being one of them. So thank you for the opportunity, Vivid Care. Okay, so there's a lot to get into here today, and let's get started with that then, Tristan. I'm not controlling the slides, by the way. So here's the learning objectives, and I hope I've covered all of these. So importantly, revision of the categories of pressure injuries, the biology bit, understanding the structure of the skin. So that's where we all have to go back to what do we remember about biology, anatomy, physiology. Definition, terminology, and statistics. We know that statistics are very frightening when they come to the seriousness of pressure injuries. Understanding the causes and risks of pressure injuries. That's really where our role comes in as healthcare professionals, because we do have a huge part to play and the responsibility when it comes to understanding the causes. Posture and how it impacts on pressure injuries. Posture and pressure red flags, reducing the risk of pressure injuries, obviously, and best practice. So that's all I want to cover today. So that's nice and straightforward. So we always have to start with definition and terminology. So importantly, with terminology, it can be confusing because pressure injuries is what the correct terminology is today, but many of us will have grown up in our careers and work with a range of skill levels that will still use the terminology pressure ulcer, which is absolutely fine, and pressure sore or bed sore. So I'm never bothered when people use that terminology. I'm bothered that they're discussing it, because that's the most important thing. So we can all be precious about correct terminology, which is pressure injury, but let's get everybody discussing it in a way that they're comfortable, in a language that feels right for them. So when we're talking to our end users, when we're talking to their relatives, when we're talking to different levels of experience and qualification, let them tell us in their language that they're comfortable with. Oh, I think they've got a bed sore. Oh, I think they've got a pressure ulcer. That's fine. You know, let's embrace all the terminology that's out there. But for us, the correct terminology today is pressure injury. So, and looking at the definition, there are many definitions about. So an injury to the skin and underlying tissues caused by pressure is called a pressure injury. So this is from EPUAP, European Pressure Ulcer Advisory Panel, and the National Pressure Injury Advisor Panel. The guidelines are currently in the process of being updated, and the new guidelines will actually go live in November the 20th, 2025, which is the Stop Pressure Ulcer Day, which I'm sure many of you are aware of. So currently we're still looking at the 2019 version. So previously known, as I've just said, in different terminology, but let's embrace the discussion rather than being precious about the correct terminology. Okay, sorry, that was a soapbox moment. I have many. Okay, next slide. So some statistics which we know are horrific and very frightening and alarming. So in the UK, let's just focus on the UK. Wood et al. 2019 found that over 700,000 patients are affected by pressure injuries each year. So that is actually much higher than that now. And we know that the older population, so people aged over 75 years, are more at risk. We'll go into that later. And pressure injuries in hospital, sorry, I'll read that again, who developed a pressure injury in hospital had their stay extended by 10 days. So we know all the pressures on healthcare, on the NHS, is to get people in and out of hospital as quickly as possible. But this is frequently delayed by a pressure injury occurring while they're in hospital, which prolongs their stay, quite rightly. Pressure injuries cost the NHS 1.4 million each day, which is 4% of its total expenditure. So these are some alarming statistics that need to be at the forefront of everybody's mind, and that's why the NHS is so hot, quite rightly, on everyone being trained to a high standard as part of their essential mandatory training. Okay. Next. So more statistics. I'm not going to read all of these slides, but we need to, you'll have a copy of the presentation afterwards. So I thought it's good just to start with some of these. So the incidence and prevalence of pressure ulcers, injuries, increases with age. We know that. So the older population, the less mobile population, the population who have increased health conditions, they are more at risk. And from the NICE guidelines, and it's estimated that just over 500,000 people will develop at least one pressure ulcer, pressure injury, and around 1 in 20 people admitted to hospital with a sudden illness will develop a pressure ulcer in any given year. So these are all like really alarming and quite frightening statistics to be reading in 2025. Okay. Next slide. And I'm not sure how many of you know this, that in 2004, pressure injuries, then called pressure ulcers, were thrown into the limelight, into the highlight, because a very famous actor, Christopher Reeve, who, as you know, had a spinal cord injury and ended up being in a powered wheelchair and having total care needs. He died from sepsis, which was caused by an infected pressure injury on his sacrum. So when a famous person dies of a heart attack, but actually then when we dig down and we see it was a pressure injury that caused his death, and that was back in 2004, this is when we all should be sitting up. So what, we 21 years later, can't believe it's been that long actually since he died, 21 years later, we still need to be reminded of it is often the cause of death. But on the death certificate, it will be something like a heart attack. But if we dig deeper down into the medical records, it will actually be the pressure injury that was the cause of death. Okay. So here's the biology bit. So nothing too gory on this slide. So let's think about our skin. Let's think about what we remember about the layers of skin. And if we look at the picture on the left saying healthy tissue, I really like to then look at the arrow which leads to organ failure, because skin is the largest organ in the body. So let's give that organ the respect of other organs that you read. Somebody has heart failure, somebody has lung disease, somebody has a brain tumor. We're all, oh my goodness, this is urgent. But actually, somebody has organ failure when they have a pressure injury. So let's look at our own skin. We all have skin around us. So mine's feeling older because I had a birthday last week. But if we look at the top layer, and that's where we see the moles, the freckles, the hairs, that's the dermis. So when we have injury to the dermis, which is an area of the skin that remains red, we'll call that a category 1 injury. And then if we look going down into the layers, so the layer directly under the dermis is the epidermis. And that's when Let's think of the importance of the epidermis. It's probably a structure that isn't as commonly talked about, but the epidermis, if we were to look at it under a microscope, if we were to cut through and look at the epidermis under a microscope, it would be a really neat, like drawn on a CAD diagram, crisscross, really neat crisscross. So go and look into this online afterwards if you're interested. But once the epidermis has been damaged and then you look at it under a microscope again, that crisscross never reknits in the same way. So if you were to look at the epidermis of healthy skin, somebody like most of ourselves who haven't had a pressure injury, versus the epidermis of skin that has been injured, so we have had a category 2 injury, it will look, the structures will never rebuild in the same way. So it won't be that beautifully drawn crisscross. There'll be little lumps, there'll be little blips, because although it may have recovered, it won't ever recover to its full structure. So that's really important to remember. I'll come back to that a few times. So then going down into the next structures of the skin, we have the fat, and we have the muscle and the fat layer. We know that fat's very stubborn and muscle's very strong. So once we start to dip down into those layers, we're coming into more serious structures. And then on the very bottom, we have the bone. So on category 3, we've gone deep down into the fat and muscle. And you can see, if you've all seen pressure injuries, pressure ulcers, I'm sure, you can see different colours, and you'll see the orange will be like the fat layer. And then unfortunately, if you've seen a category 4, you will be able to see right down to the bone. So on terminology again, before I forget, so categories is the correct terminology now, but there's nothing wrong with saying stage or grade, because those terms are still used. So I often see somebody every week, and sometimes every day, and I'll be told by a carer or a family member, or they've got a grade 3. I'll know that means a category 3. So I'll just inquire and say, who's told you this? Is it been officially diagnosed, or is it just people passing comment? But they'll rarely use the terminology category. So again, let's just embrace the conversation and not get too hung up on the terminology they're using. So that's organ failure. Have another slide similar coming next, which just shows it more on body parts. So it shows what category 1 looks like, which is a red non-blanchable erythema that doesn't go away. So if we press down on our own skin, and you'll see redness, but when we remove the pressure, the redness will disappear. So that's fine. It's when there's prolonged redness that remains. So that's an image looking on the skin structure, but also on the skin. And then if we look at category 2, we will see that there's a partial thickness skin loss, and you can start to see that the skin is broken away. It can sometimes even resemble, if we remember as children, or if we have children, when they fall and graze, and you can see like the stickiness of it, the moisture there. So, and you can see that we've gone down through the dermis into the epidermis. Category 3, looking from above there, you can see the full thickness skin loss, and you can see the different colour there. The orangey yellowy part is where you're going down through to the fat. The skin around isn't smooth. It's can appear like very irregular shaped. And then category 4, you have the full thickness tissue loss going right down to the bone. So that is sometimes good. I know we have these posters on our walls at work or in textbooks, but it's good just to take time to really understand what those categories, stroke grade, stroke stage mean. So that's really important. Okay, next slide. And not discussed as often, but the deep tissue injury, and can be really difficult for an inexperienced eye to understand. Can also be difficult on different skin tones to see. So we need to be aware on different skin tones on black skin that it is really difficult to identify, commonly seen on heels. People have been prolonged periods in bed when we haven't got good positioning in bed systems to offload. And this is where the tissue is deformed, squeezed and stretched between a bony prominence and the seated surface or the bed surface. And it's where the difficulties coming from inside out. So cell death through deformation can occur in minutes. So this is a really quick process and can be very difficult to treat. So cell death will occur and we can be very unaware of it. So good skin examination needs to take place. So there's some more science images there. So it's not one that we discuss as commonly, I don't feel, as therapists, but certainly as nurses, it will be always on the radar. But as therapists, we're more focusing, I feel, in my experience, on the stages 1 to 4 and less so on the deep tissue injuries. On a similar note, there is another category which again is up for debate whether it will continue to be discussed, and that's when there's an unstageable injury. That's because it's so difficult to see the damage that has occurred, the level of organ failure that's occurring in the skin, that it'll be classed as unstageable. And again, that's a very common practice to be used in nursing care. Okay, next slide. So let's say, hopefully we all know what pressure injuries are caused by, but let's revise this together. So prolonged application of external mechanical forces, and the forces can appear in different formats. So direct pressure, so that's when we have direct pressure. So let's think of how we're seated now. Are we all seated in a good posture? Are we all sitting on our sitting bones, on our ischial tuberosities? I have my friend the pelvis with me always. Are we all loading here on our ITs? So if we're loading on our ITs and we're sat on a firm, horrible chair at work, I've actually put a cushion under my bottom, we will feel after a while that we need to do a little shuffle because our bony prominences are shouting, ow, it's too much pressure, I'm sat on a firm surface. So you will know this if you're sat on a bench, if you're sat on a wall, if you're sat in a cheap theatre seat, for example. But the clients, the individuals we work with won't feel that direct pressure. So they'll have prolonged pressure, and then we need our responsibilities to make sure they have the correct support surface to protect their skin from that direct pressure. The next cause would be shear. And this is when, if we think of it as a really aggressive force, so it's when, if you look at, again, the skin on your arm and look how it can move, well, it can move the same on all parts of our body. And when there's less skin and our skin's older and it's moving against a bony prominence, it's a really aggressive force. So it's a stretching, a sliding force. So think of sliding across a transfer board, think of sliding from a home chair to a wheelchair, think of sliding from a bed to a commode. All of those forces will involve shear when somebody doesn't have the strongest upper limb ability. So their body may be, the skin on their bottom will be dragged, it'll be pushed in opposite directions. So it's a twisting, it's a sliding force. But let's not confuse that with friction. So friction and shear are often confused and the terminology is often used incorrectly. So friction involves the skin rubbing against a surface, which can harm the protective outer layer. When we know the protective outer layer is called the dermis. So when we're sliding across bed sheets, so in the olden days, hopefully we can call them olden days, when people were pulled up beds, their skin was shearing on the sheets. So think of a cushion and a cushion cover. So if somebody's put a tea towel over their cushion in their home chair or in the wheelchair because they had a lot of leaks, we put a little soft tea towel over it. How does that support surface then interact with their skin? So friction and shear can work together. You can have both forces really causing a complication, and this will cause deeper damage, more serious damage. So when we combine all of the other additional risks that I'm going to talk about, like the level of somebody's lack of mobility, poor nutrition, moisture when somebody's sweating or sat in moist environments such as a leaking pad, a wet pad, then we have a real increased risk of pressure injuries. Okay, next. So let's look at the seat. Let's call it seat or let's call it cushion. It's the same thing really. And objective. So what do we want to do? We want to reduce tissue deformation. We want to protect the layers of the skin. We want to protect this important organ. So we want to minimize the risk of pressure injuries by looking at postural control. So I don't feel as therapists, obviously I am a therapist and OT, I'm not a nurse, that we can talk about pressure risks without talking about posture. What is a real hot topic for me and a real soapbox moment is so many of the practices within the NHS are all about skin, dressing skin wounds, stressing, giving artificial skin barriers. I'm not a nurse, I'm not a tissue viability nurse, I'm sort of floundering a bit here. But very often I'll see somebody on the ward and it's all about how long they're in bed, that they can't sit out. But it doesn't talk about posture. And this is what I find all the time. And even with the risk assessments that are used, they rarely talk about posture. So talking about the support surface, what material is the cushion that we're sitting the person on, whether it's in a wheelchair or whether it's a home chair? What material is it? So what materials do we know? We know there's different foams. Different foams have different foam qualities. We know that there's air cell products. We know that there's complete air products where you have one big bladder of air versus individual air cells, vertical air cells. We know that these materials have risk factors put against them. So they'll be called a high risk cushion or a medium risk cushion. But really, we have to do that risk assessment. We have to understand our clients to say what support surface is suitable for them. Does that support surface allow immersion and envelopment? What clinical reasoning are you using when you're selecting a cushion? So I can know in my role in the wheelchair service that I will have put somebody on what I feel is the best cushion for their posture. It's the best protection I could possibly give them. But if they're not seated well on it, if it's not positioned correctly in the wheelchair or in the home chair, I may as well have sat them on a cardboard box. Sorry, I'm being a bit silly there, but you can give the best cushion in the world, but if somebody has poor posture and they're not being seated and positioned correctly when they're hoisted into the wheelchair or hoisted into the home chair, that cushion is not going to work. So I have a little tiny, I'm trying to do a little homemade illustration here. And it's a bit of a cut side profile of foam, as you can see here. Not great, it's better if we're face to face. So we have a well at the back here. It's a mini one because I wanted to be able to hold it. And we want the pelvis to be seated in the well, don't we? But in that well, they'll rarely just be sat on a thin evazote like this. We have ramping here to block the pelvis to hold it upright. And then let's just say in that well, we've chosen a gel or an air or a foam, doesn't matter which one, I'm just trying to illustrate. So what we're wanting to do is the pelvis to be held and for that pelvis to hit, so the ITs, the ischial tuberosities, to hit the support surface that we've chosen. In this case, it's some gel clusters. It could be air cell, it could be foam. But if the person is not seated correctly in there, what will happen? They'll go here. So the area of the pelvis that we want to protect, the ischial tuberosities, which is where there's been a recurring category 3 injury, we wanted to protect them here, aren't we? But actually they've been hoisted in poorly. People haven't understood their posture, so they've landed here. So we've given them great cushion, we've reasoned clinically what they need, but we're not actually, the cushion isn't able to do its job due to poor positioning, to not understanding from the healthcare professional who's hoisted them in. Sorry, it's not great. I'm just trying to illustrate a really simple thing, how we can give a cushion with a well, with gel in the back or air in the back, but they're not hitting that. So then what will happen, we'll have a transition between the different support surfaces. So we could be hitting the firm foam, which needs to be firm because it needs to block the pelvis in an upright position, in a neutral alignment, but actually due to posterior pelvic tilt, they're loading here. And then if we look at their sacrum coccyx, that's missing as well. So sorry, it's trying to do a simple illustration versus another soapbox moment. So we need to ensure that although selecting the correct cushion is important and vital, and that's our role as clinicians, it needs to accommodate for optimum positioning. We need to make sure that if there's pelvic obliquity, that we're correcting that. If the pelvis is rotated, we're correcting that. So pelvic obliquity, the pelvis rolls back, pelvic rotation, one side is forward to the other, and pelvic obliquity, one side is higher than the other. So it's not as simple as just giving them, wow, I've given them this amazing cushion. I've been told by the rep that it's a high risk cushion. Everything's going to be absolutely fine now. Tick, done. I'm being a bit blasé, but please roll with me here. So unless correct postural alignment is in place, unless we've done our full postural review, the cushion isn't going to be a miracle worker on its own, whether it be in a home chair, whether it be in a wheelchair. It has to have the whole process together. And importantly, at the bottom, comfort, which actually Tristan referred to right at the start. We have to increase sitting tolerance, and we have to increase participation and quality of life, because comfort is a word as clinicians that we're scared to use. We think it's too subjective, but without comfort, again, the best cushion in the world isn't going to be used. If somebody sits on it for 15 minutes and they're uncomfortable, they have such low sitting tolerance because they need to build up if they've been on bed rest for all that time. So we have to understand that individual user's level of sitting tolerance and comfort. Next slide. Sorry, it's a long one. I do ramble a little bit. So we've all probably seen this skin bundle, but just to briefly recap on this, so preventing pressure ulcers, we'll often see this on hospital walls, in clinic rooms, that we must consider the skin bundle. So skin, so surface, what is the surface? So what cushion material have we selected? Who has selected it? Are they an experienced healthcare professional? Do they understand cushions? Is the cushion in the correct way round? Many times I'll go and review somebody and the cushion is the wrong way round because lots of carers are involved. The cushion cover could have been taken off to be washed, and then the cushion's put back in upside down. I'm sure we've all seen this, even though all manufacturers, majority of manufacturers, are labeling front, side, back, and you'll say the zip must be at the back, this sign must be at the side, the contour is at the front. You will still see it placed in the wrong way. I saw it just last week at least twice. So that's the surface. Do we need foam? Do we need gel? Do we need air cell? Do we need a hybrid cushion? And then skin inspection. Who is inspecting this skin? In hospital, that's straightforward. The skin will be inspected regularly by nurses, by healthcare assistants. When they go home, who's inspecting that skin? Are they an elderly couple? Does the wife understand that her husband's skin has broken down, or does she just think it needs a bit of Vaseline on it? So skin inspection. Keep moving for the K. So frequent changes of position are absolutely key. We cannot expect individuals to be sat in the same position, but with limited care packages in place, often due to financial constraints, I will see many people that they're sat in their wheelchair 6-8 hours between care calls, or they remain in bed without being turned. Yes, they may be on an protective air mattress, but they're laying in that one static position until their next care call. We see this all the time, don't we? And it's really, really sad. Many people live alone. They're waiting for the next care call. They may have been hoisted into a home chair, which was assessed for them, but is no longer suitable. They may be sliding out of that chair. So keep moving. That's the K. I, for incontinence, we know that incontinence hugely increases the risk of pressure injuries, of the skin becoming moist, sitting in a warm environment that's full of bacteria. So if that person is incontinent, they're at higher risk of skin breakdown. And nutrition, what is that person's nutrition? Do they have good nutrition? Are they drinking enough? Do they have the correct nutrition in place? So that is the skin bundle, which I'm sure we're all aware of, but it's good to just keep talking about. Next slide. So risk assessment. This isn't a talk about Waterloo or Purpose T. I must just state that. There are many webinars about that available, and within your own work organisations, there'll be plenty of mandatory training about that. But we just need to know who are the people at risk. Well, they're majority adults, and we know that older adults are at greater risk. So use the agreed risk assessment tool that's in your organisation. We're phasing away from water towards Purpose T, and since 2023, NHS England stated that all health NHS organisations should be using Purpose T. So I'm sure this is a term that you've all heard and you're all getting to grips with. But adults considered to be at high risk will usually have multiple risk factors. So we can attend many mandatory training courses about these risk factors. We'll all have to, our course is on orange, we must redo it, we must renew that course. But again, I will say all of these courses, whether they're Waterloo, whether they're Purpose T, they will all refer to the risks. They won't really touch on posture. And I don't know whether as anybody's recently completed one of these mandatory courses. I have recently done one a couple of weeks ago in my NHS role, and actually, was posture mentioned in it? No, not really. It was all about the other risks. So how can we look as healthcare professionals, particularly therapists, at preventing these risks, giving our best advice, advocating for these vulnerable clients when we're not talking about posture? It absolutely, in 2025, flabbergasted me that this is still the case. And it does show that there's not enough linking up between different healthcare professionals, that it is looking at skin integrity and the excellent work of our nurses and tissue viability nurses who are really excellent in their field. And then we've got these highly skilled therapists. But really, the two practices need to go hand in hand all of the time. So adults with a history of pressure injuries or a current pressure injury are also considered to be high risk. So going back to what I said about the skin mesh and the looking through the microscope, if somebody says to you, I'm absolutely fine. Yeah, a few years ago, I did have, what did they call it? Oh, yeah, I think it was a grade 2. I had a grade 2 a couple of years ago. I'm absolutely fine now. No worries at all. I'm good with this cushion. You look at them on the thinnest foam cushion they could be on because they're an active user and they just want something lightweight to throw on and off their very high-end active chair. But the fact that they've said to me 2 years ago they think they had a grade 2 is red flag for me always, because I know that their skin integrity has not recovered to where they think it has, and it will always remain vulnerable. So next slide, please. So prevention, it says adults because they're the highest risk group. So be aware that all patients are potentially at risk of developing pressure ulcers. So we have a responsibility to everybody, but there is a higher risk for adults. And we need to be aware of those clients who have significantly limited mobility. One example, obviously, is spinal cord injury, significant loss of sensation, a previous or current pressure injury, as I've just said, nutritional deficiency, and the inability to reposition themselves. So anybody that requires healthcare professionals to position them, they cannot do a pressure shift. We know all about pressure shifts. The individuals we're talking about, these older adults, they cannot do that themselves, many of them. So they are all high risk. Okay, next slide. And then repositioning. So we will always encourage those that can reposition to do it. And by repositioning, we're not just talking about them doing a weight shift. We're talking about them using the tilt in space. So how many of our clients that we've worked with, you've had to go to the end of the world to justify that they need a tilt in space chair, whether it's a wheelchair, whether it's an armchair, and then you'll go and see them to review them and they're sat upright. And we'll go, okay, so how often do you use the tilt? Every day, like once a day. Yeah, once a day. No. So what I say to all clients that I'm working with is you need to be using the tilt every hour. And I will advise to use the tilt for 15 minutes in every hour. And I don't just mean a little tilt. I mean, sit in tilt, relax in tilt, listen to music in tilt, have a conversation in tilt, watch telly in tilt. The fact they're saying to you, yes, I use it every day. Do you ask how often do you use it every day? When do you use it? Are you fully tilting? Are you just slightly tilting? And they will ask things like, well, I can't eat when I'm tilting. No, I'm not saying eat when you're tilting or drink when you're tilting. I'm saying use it. And I'll even say to clients, set a little timer in that hour. Have I tilted? Have I allowed my body to rest? Have I taken the pressure off loading on my seated surfaces and put the pressure onto my back? So there's many guidelines and documentations about best practice with tilt in space, and the greater the tilt, the more effective for pressure relief. So asking the question, when do you use the tilt? How do you use the tilt is really important. So clients at high risk need to change their position. And when I mean change position, I mean go from seating to lying or go into full tilt, and they should never be sitting for longer than 4 hours. So to give out guidelines on safe levels of sitting is really good practice. So somebody with an existing pressure injury, category 3 or 4 pressure injury, should be doing very limited sitting. Like maximum 1 hour, and on a suitable support surface and using tilt. It doesn't mean that that person should never be sitting. So we have so much practice saying the person needs to stay in bed, they need to stay in bed, but actually getting out of bed, even for that short time, allowing the blood flow, the capillaries to come out of lying into sitting is really important, because what we end up with otherwise are a whole group of clients that have lost their ability to sit. It's been so long since they've sat. I've seen individuals that have been on bed rest for 2 years because of a higher graded pressure injury, and then we expect them to go back into an armchair or back into a wheelchair, and they've lost their core, they've lost their ability to sit. Okay, next slide. I'm really going over time here. I'll slip through some of these. So clinical assessment for pressure redistribution cushion. So again, I sort of covered this, but I'll recap on it. So we need to look at the pelvic position. Seating solutions should always consider posture. So it's, again, no point giving the best cushion if we haven't considered their posture. So pelvic position, influences of their spinal shape, neck and head position. How stable are they in sitting? So can they cope without tilt? Can they sit upright? How do they cope when they're not in their armchair, when they're in the wheelchair? Can they cope with being pushed around and still maintain their upright posture? And what diagnosis? Is their condition stable? Is it a degenerative condition? Is it a neurological condition? So we know that you could see somebody on that morning and you go back the following day in the afternoon, you think it was, am I seeing the same person here? Is this the person I saw yesterday morning? So make sure that the seating you're providing will accommodate for the changing in their postural needs from day to day, from morning to afternoon, on their best day, on their worst day. Will the seating you provide and the cushion you provide accommodate their changing future-proof needs on their worst day? That's what I would always ask myself. So risk overview to consider, a bit of common sense, but let's talk about them. Clothing, hoistling, what cushion, obviously, mattress, time spent in each position. Are they sliding? If they're sliding, that's a red flag that they're not in the correct seat, or they're not on the correct cushion, or they've not actually been positioned correctly by the carers who have transferred them from bed to chair. What is their continence? What is their hydration? Are they overweight? Are they underweight? We need to know what is causing this pressure injury. It's not just good enough saying, right, put them on bed rest, they've got a pressure injury. They're a category 3, put them on bed rest, because actually when or if that heals, we've got to go loop back to what caused it, because if we don't solve the issue with posture, it will happen again, it will break down again. So we continue in this loop of, were we the detective? Did we use our clinical reasoning to understand what has caused that pressure injury? Okay, next slide. So the most common sites for pressure injuries when seated. This is a wheelchair image, but relate it to whatever seating we're talking about. So I will always, in my work, usually be dealing with clients who have recurring pressure injuries on their seated surface. So here comes my friend the pelvis again. So it will usually be on their ischial tuberosities, their sitting bones. It could be just on one rather than on both, and that will be because they have a pelvic obliquity, so they're loading heavily here, so they are at risk on that one IT. It could be that they're sat in such posterior tilt and they're loading on their coccyx sacrum, so that's where the pressure injury is. It could be a combination. So we need to know what has caused that. Should we be leveling the pelvis to stop the loading on the one IT? Should we be looking at a cushion that accommodates and allows for realignment of the pelvic obliquity? We should be giving a seat. This multiple piece of foam here is coming into play. We should be blocking their blocking from behind so that their pelvis cannot roll into posterior tilt. So supporting the pelvis in a well, but also blocking, making sure that the back support is giving good enough support to the PSIS behind and helping maintain with good sacral support to stop this rolling. So apart from the pelvis, we'll have in seating pressure injuries sometimes behind the back of the knee. That could be that the seat is too long, or that somebody has really tight contracted hamstrings, which can cause injury there. We can also get moisture, sweating there when we've got tight contractions. We'll see injuries in sitting and lying on the feet, particularly the heels. And also we can have loading on the scapula, on the shoulder blades in seating. So have we got the correct support surface behind the back? Are we using tilt? Are we using with caution, tilt and recline? So areas that are most under pressure will be the areas that have the peak pressure and are at greatest risk from developing pressure injury. So again, we have to be that detective. We have to be the therapist or nurse, or both in combination ideally, that goes and says, we know they have a category 3 injury. What has caused it? Why is it there? Why isn't it recovering? What could we change to make sure when we do get some recovery that this doesn't occur again? Okay, next slide. So how do we reduce the risk of developing pressure injuries? I'm sort of saying this throughout, but I like to keep recapping on a slide. So frequent changes of position in lying or sitting. So leaving somebody in the same position for too long is going to be a massive red flag. So, and when I say frequent changes of position, it doesn't mean that we have to keep hoisting them from chair to chair to chair, but it also doesn't mean that they should think that one chair is fine. So a wheelchair cannot do the job of everything. You need alternative seating. It's really sad, isn't it, that we see many people that don't have appropriate home seating, They just have their wheelchair or bed, and that they are in that wheelchair or bed all day. And then when I review somebody in a clinic, I'll say, how long are you in the wheelchair for? And they'll go, all day long. Well, why aren't you going into a home chair? I don't have one. So that is a common thing we hear. So it's bed or wheelchair. The wheelchair was never intended to be an all day long piece of equipment. For some active users who are going out to work and they're doing self-transfers and car transfers, yes, it will be their all-day seating. But I'm talking about the older category who we're discussing, the vulnerable people who can't move themselves. We can't expect them to be in a wheelchair all day, so they do need an appropriately assessed supportive tilt home chair with appropriate support surfaces. So specialist mattresses and pressure redistribution cushions that have been clinically assessed for the individual. Of course, that's how we reduce the risk. But we know sometimes that can still go wrong. As we said, the cushion can be the wrong way up. So we could have done our best job, done our detective work, and then that's out of our control once they're discharged, or if nobody's visiting them in the community. How do we know that what we put in place in our best practice is being used in the correct way? Same with mattresses. How do we know if somebody's air mattress has stopped working? Who's reporting that? Do they have a reliable care going in? Does the spouse understand that the air mattress is broken? Is the foam mattress the correct foam mattress? So majority of pressure injuries arise from sitting or lying in the same position for a long period without moving. And this was from NHS England. Okay, next slide. So again, recapping, I think we've covered this. Who's most at risk? So those that are unable to change their position independently, those who have asymmetry in their trunk and pelvis, where there are peak pressures because of asymmetrical loading on the support surface. Even the best support surface that we clinically assess for, if there is uneven loading, there will be peak pressures. You may be sitting them on the gel that you've chosen, you may be sitting them on air cell, but you can still have peak pressures when the pelvis has not been corrected, has not been aligned, or if they've not been hoisted correctly into that piece of equipment. So we know that there's a huge change of carers. Many people are dependent on carers to perform their transfers, and the carers can change. The agencies have sent somebody in that's never met the person before, that they're not going to follow the exact practice because it's the first time they've met the person. The person won't be assertive enough or may not have independent communication to say, I don't think I'm sat well. So the people we're dealing with have complex medical needs. Many of them have executive functioning difficulties following strokes. Many of them don't have the ability to communicate their own needs. So these are the ones that are so vulnerable and most at risk. Next slide. So skin quality and age differences. This is a little bit common sense, but yeah, I was looking for, I had a wonderful picture that I couldn't find, and it was of two bottoms, and it was a nice young bottom versus a bottom that we see when we're turning people, an elderly bottom when the skin integrity is so poor, the elasticity is gone, there's very little fleshy covering, and there's bone. You can just see the bone definition when you roll somebody. These are the skin images that we see and we deal with. So skin changes with age. We know that. We can see that looking. This could be my own hands, I feel, actually. I'm trying to use more moisturiser. But we know how our skin ages, don't we? And look for the visible signs. So the skin becomes thinner. Look how quickly elderly people bruise. Look how quickly their skin will cut. I think many of them are on medication that makes them very vulnerable to a cut. So all of these things are things we're battling against with aging skin and the differences to young to older skin. And that's why many, although a young person can seem high risk, and they will be high risk with complex posture, you very rarely see children, however complex they are, and young people with more complex skin injuries. Okay, next slide. So essentials for posture and pressure care. So hopefully we all agree, and we all have had enough of me ranting on about it, the importance of good posture. So maintaining and supporting symmetrical posture can help reduce the risk of pressure injuries. It's especially crucial for people with limited mobility. That is something that I shouldn't even need to say. We shouldn't even need to be sitting here and listening to, because it's fundamental to healthcare that the importance of good posture goes hand in hand with pressure care and reducing more serious pressure injuries in our elderly and complex populations. But again, I'll say, very rarely is it mentioned in any of these trainings we attend. So it's something that we have to keep shouting about. So regular position changes are crucial. I've already discussed that, but we have to take away the risk of prolonged peak pressures by allowing people to remain in poor postures. And we have to get away from, they should be on bed rest. They should be on bed rest. Yes, they should be on bed rest, but not for 2 years. And I've seen so many individuals that they've been on bed rest for 2 years. What is the risk to their mental health? I've seen people that have said, I just want to kill myself. I cannot remain on bed rest any longer. So we have to get people out of bed, into a correct seat, into the correct, allow for tilting space, and working with skilled healthcare providers to make everyone understand that somebody doesn't have to be on bed rest for 2 years and only allowed out of bed for personal care. I have seen that so many times. And the use of appropriate supportive aids, appropriate supportive cushions, and the use of tilt and recline help to protect vulnerable skin. This is, again, common sense, but we have to promote comfort and reducing the risk of pressure injuries. If somebody isn't comfortable, if the chair hasn't been set up properly for them, it could be the best chair in the world, it could be the best cushion in the world, but it's not going to work for that individual if it's not being properly assessed for, and if it's not being reviewed. You have to review these people. Okay, next slide. So I have managed miraculously to sort of stick to time here with a lot of rambling. So closing points to remember. I could have like a million soapbox moments here, but so we need to identify individuals at risk, and applying effective prevention strategies. This can help prevent pressure ulcers. But looking at this quote here from 2011, so again 14 years ago, regular repositioning is a simple yet effective preventative action that all healthcare professionals can perform within their scope of practice. So that was said 14 years ago, but still I see people that have been in bed for 2 years. Still I see people that are not provided with a tilting space armchair because they don't meet the criteria. So how in 2025, in the final quarter of 2025, should we need to be reminded of the importance of regular position changes and how fundamental that is to preventing pressure injuries? We can go on every course that's out there. We can look at all the wonders of risk assessments, and we do need to understand them and know them. It is our duty. But unless we use common sense, and unless we use our therapeutic skills about going back to good practice with posture, we're never going to make a change with these injuries. So as I said at the start, the new guidelines from EPUAP will go live on the 20th of November, which is the Stop Pressure Ulcer Day. I've been very lucky in my career when I've worked for different commercial companies to have attended 2 of the EPUAP conferences, one in Belfast and then one in Lyon. But what I'll say from those conferences, having attended them, nearly every exhibition stand there is about skin dressings, artificial skin barriers. You walk around the exhibitions, very few are about posture, are about cushions, or about that. They are all about mattresses actually, and they're all about wound coverings. Sorry, that's not the correct terminology because I'm not a nurse, but you know what I mean, skin dressings. And it will not ever be talking about posture. And I just think what is happening here? The same. I've been to the tissue viability conference. Same again. It's all about beds, mattresses, skin dressings. So for me as an OT of 33 years, I find that quite sad that we're actually not joining this thinking together. Do you all remember the wonders of Agenda for Change? You know, how that all came about and that was going to improve everything a long time ago. It has improved a lot, but one quote that sticks with me from Agenda for Change, and one I use time and time again in many presentations, is if we always do what we've always done, we'll always get what we've always got. And that is so true. So if we continue to just focus on the bed rest, on this, on that, and we don't change to join up our high level of expertise within different healthcare professionals, if we don't talk to therapists about posture or don't talk to tissue viability nurses, if we don't look at these complex people together, we're always doing what we've always done, and we're not going to make real lasting changes for these people. And we're going to continue with that frightening statistic of whatever it was at the beginning, £1.4 million. You know, we have to make changes. So that's my soapbox over. I think there's one final slide and then I'll shut up. So yes, it was just a smiley face actually, because I've rambled a lot. So thank you for attending this webinar. As I said at the start, I know how important CPD time is, and thank you for choosing to spend some of your CPD time attending this webinar. I hope it's been useful. Thank you to Vivid Care for asking me to come and ramble for an hour. Hopefully some of it was useful and hopefully none of it was offensive. Okay, thank you.
Thank you very much, Jo, much appreciated. So from now we have two final bits to this webinar. First of all, I'll be going down to our assessment and demonstration room just to go through some of the features that we've talked about on the chairs and linking them back to Jo's presentation, just to actually physically show you how different aspects, different functionality of different chairs can make a real impact for that pressure care. After that, we'll be hosting the Q&A section, question and answer section with Jo. So please do pop any questions that you've got on the chat, on the meeting chat here. I can see some have come through already, so we will be covering those in a few moments' time. So just bear with me one moment while I run downstairs, and then we'll through some of the chair features just to bring it to life. Thank you. Hello everyone, can people hear me? Excellent, thank you for the nod there. We'll just, there we go. Very good, thank you. So I've just come into our demonstration area just to show you, as I mentioned, some of the features of a lot of the specialist chairs out there, but I'm going to use for this our Lento Care chair. So it's one of our own range of seating, as I mentioned at the beginning, and a care chair obviously has the larger wheels and it's designed for someone who's hoisted, so someone that's not able to move their position, as Jo talked about, and someone who needs a good level of support and a good level of pressure relief. So Jo mentioned a lot about the posture side of things and how important that is, and I think one of the key things that we do in all our specialist seating assessments when we're going out to see different clients but also in the hospital environment, is to look at the seat sizing, because seat sizing has a massive impact on someone's posture and on someone's pressure care. So we can think about this very simply. If we think about myself on a long haul flight, I'm a short guy. I'm only 5'5", and I actually put the pillow underneath my feet, because you start building up pressure under your thighs, you end up with pins and needles, and the tissue is being compressed. So that's just a little simple illustration as to the seat sizing, how important that is. You and I, we can move our positioning around, but for someone who's sat in this type of chair, they can't do that. So it's really important to get the seat sizing right. Specifically, the seat depth and the seat height are some of the most important measurements, but we've also got seat width and arm height and back height too. So a good chair, a good specialist chair, will have the ability to be able to adjust that seat sizing for each individual to get it just right for them. So I'll just cover off that on the Lento Care chair. So first of all, on the seat depth, we've got a little pull pin here, which just comes out, and we've got a handle on the back here. And if I just spin this round so that you can see the front of the chair, pop the brakes on there, you'll see we've got a lot of seat depth adjustment on there. So we can actually get someone who's say 5'2" in this chair, right up to, we've had someone of 6'11". So that's really important to have that seat depth adjustment. Second measurement we talked about was the seat width. So seat width, we've got two little screw knobs either side at the back here. You just slacken those off with your fingers there, and then you've got adjustment in seat width. And that's important because obviously you don't want it too narrow, because it would be pushing against the hips there. You want about a hand's width either side of the hips. But if it's too wide, we end up with other issues, people leaning to one side, which in turn puts pressure on different areas of the body, as Joe was talking about. So seat width is also important. But on the Lento Care chair, as well as the seat width adjustment, once you've slackened off these arms, you can pull the arms all the way out. So obviously for side transfers, that kind of thing. But the key thing I wanted to show was that once you've taken this arm off, you've actually got a couple of pull pins, and you can change the arm height as well. And that's important, I think, often in seating. I think that's sometimes forgotten about, but obviously our elbows and other areas, wrists, etc., they are bony prominences, and we can build up pressure in those areas, and the elbow particularly is an area at risk. So getting that arm height correct can give the correct support all the way along the arm, but also, again, stop leaning to one side or pushing the shoulders up, stop that build-up of pressure in any one area. Next feature, I want to, just one last area here is the foot plate height. So obviously we want support all the way along the thigh there, but we don't want the foot plate height too high, because otherwise all our weight's going to go through the sacrum, through the ischial tuberosities, and build up pressure there. But we don't want it too low, because as I said about the example of the long haul flight, for me, you get a build up of pressure under your thighs here. So very important to get your seat height correct as well. We mentioned a lot about tilting space, and I'm sure pretty much everyone on this call will have experienced what tilting space is. But just in case there's anyone who doesn't, tilting space is this action here. So what we're doing is we're rocking back the chair almost like a cradle. So the seat and the backrest are moving back together. And this is so important, as Joe said, for pressure care. So why is that? Well, obviously we're spreading the weight not from the buttocks area right through across a larger surface area on the backrest as well. And that really does reduce that peak pressure on the ischial tuberosities and the coccyx area. But as well as that, we're stopping that sliding out. So Joe spoke about shear and friction, and that's what can occur if we're in the normal position, if we're in an upright seated position. But the tilting space helps reduce that. So a really key feature to use. And Joe spoke about changing positioning throughout the day. Very important to use that functionality. And then obviously looking at these surfaces, we've got on the user contact surfaces and on the arms, we do on the Lento Care chair as well. We have this special fabric. So some people call it Dartex, which is a brand name a bit like Hoover is for vacuum cleaners. Or another word for it is vapor permeable or VP. And the reason we use this fabric is that it's a four-way stretch material, very thin, stretchy material. So it really follows the shape of the cushion or support surface, so that you get maximum benefit, maximum immersion to spread that pressure and align to the body shape of the individual. So it's the same type of material you'll get on a specialist mattress, for instance, in a care home or in a hospital. But as well as that, as well as having that stretch, it's breathable, which is really important, because as Joe said, if you've got any kind of buildup of sweat, or you've not got the air circulation, that too can really make conditions ripe for a pressure ulcer to form, pressure injury to form. And then it's waterproof as well, which obviously if you don't want any incontinence, etc., to affect the chair cushioning, etc. So it's very important, we feel, to have this type of material on the user contact surfaces, including the arms and the backrest and the seat and leg area there, so that you get the maximum benefit of the pressure care. And then coming further down, I'm just going to reduce take the arm off there so that you can see better. But we've actually got the support cushion here, and we've got a solid seat base underneath the cushion, so that we can very much change the cushion to suit the patient. So Joe spoke about doing the clinical reasoning and working out what's the best support surface for this individual. As standard, we do like a medium pressure relief on the Lento range, which is a visco memory foam, so it gives some immersion. But this particular one has got a high pressure relief, which is, I don't know whether you can see, but there's little nodules here, little hexagons of what we call a cool gel material. So you've got lines between there to help the airflow underneath the surface, underneath the fabric here. But also these little nodules, if you've got more pressure build up in a particular area, it helps distribute the pressure more. Now this top layer of gel is actually a similar makeup to human tissue, so to provide that maximum kind of pressure relief, but it's also a cooling gel, so try to cool down the skin so that we don't get that buildup of sweating. But as I said, it's a removable seat cushion with a seat board in here, so that means we can use any type of cushion on there that's going to be suitable for an individual. So and Joe was talking about one with a well at the back. So you can actually have a specialist cushion to really kind of bring the pelvis into that well, maybe have a gel section at the back, and you can actually adjust some of these cushions. You can have like a custom cushion where you can move different components around inside and get that support right for that particular individual. So that kind of gives a bit of a insight into some of the different features of the chairs. There's obviously loads of accessories, loads of different kind of options and ways of using the chairs, but I've just kind of covered some of the main areas to look for when looking for or specifying a specialist chair for someone who's at risk of pressure sores. So that's that section done, and we'll move on to the Q&A section. If we can just give a couple of more minutes, and I'll be back upstairs and we'll be ready to take questions. Please do put them in the chat if you haven't already. Thank you. Just a moment. Thank you all for waiting there. So we're on to the Q&A section now. Thank you very much for putting them in the chat here. The first question is from Mary Site. I'd love to have links and recommendations for different types of cushions and products. So obviously I've gone through some of the different products available that we provide. Care chair. There's a lot of Lento chairs on our site, and I've mentioned the modular cushion too, which is an STX cushion, which we can pop a link out afterwards. But Joe, I wondered whether you might just kind of through some of the products that you've used.
Yeah, so I don't really want to recommend products. It's tricky when I'm supposed to be like independent and when I'm obviously in the NHS as well. So I think the most important thing would be understanding the correct choices and using your clinical reasoning for that. So yeah, as I said earlier about immersion and envelopment, that with foam cushions, there are some excellent foam cushions on the market and different foam materials, but we need to make sure that that foam allows for the person to immerse into it. So sorry, I've got this little homemade thing here again. So with a firm foam, so we wouldn't be sitting anybody directly onto an evazote, but if you can see with a firm foam, you cannot immerse into it. So you're always going to, even though you've placed a cushion under somebody, you're not going to allow them to immerse in. So immersion is how we can sink in, and envelopment is better with an elbow, is how something wraps around. So if you think of envelopment, remember it like an envelope. That's how I remember it. And immersion is sinking in. So if you've got a product that has gel within it, so that can be a gel sheet that goes in a well, or it can be individual gel clusters that are secured strategically within a well, and that can be used to accommodate pelvic obliquity. So choose the correct surface. So look into the cushions. Do I want a foam cushion? There are very good foam options out there, and that would be your first starting point, I would say. But I would always say make sure it's a contoured foam cushion, because none of our bodies are really flat, are they? So we need our bodies to sink into the contours. We need a well for the pelvis, even if it's only a shallow well. And we need some contouring at the front of the cushion to just do some gentle, neutral alignment of the femurs. So if we've got a flat cushion, even though we can sink into the flat cushion, it's not helping us to like work with those natural alignments of our body. Then the next support surface would be, I'd be looking at including something with the foam. So I might be looking at foam and gel together, or foam and air together. So that would be more of a using two surfaces, like a hybrid product. So you can often have gel in the well, which there are many manufacturers that offer this, or you can have a gel overlay that will go over the whole cushion. So that can be really comfortable. And this word comfort, I think as clinicians, we're scared. In our clinical justification, I went for that cushion because the client was comfortable. Actually, yes, please say that, because it isn't ever not clinical enough to say that somebody's comfortable. Like, you can be comfortable in one car seat, whereas I'd be comfortable in a different car seat. And that would be down to things like Tristan said, to do with our height. I'm 5'1". So I struggle to get comfortable on many standard office chairs. And I choose often to stand at work on using a standing desk, because the majority of seating isn't set up for people of 5'1", and I don't have any postural limitations. But so everything is very individual would be the answer. And then the top category, if you've tried all those things and there's still a recurring pressure injury that's persistent, I would say the top category would be looking at air cell. But air cell will be amazing for some people, but for others it has some other complications where carers will mess with it. So if it's an air cell cushion where you have to adjust the pressure with a pump, people will overinflate, and then you've got peak pressures because it's like sitting on a board if it's overinflated. Think of a lilo. If you've got too much air in a lilo, it's rock hard. If some of the air comes out, you sink into it, but it's still one big bladder of air. So with air cell, you've got individual vertical air cells which control it. And then in some other cushions, you have like triangular shapes of air. I'm trying not to mention product names. Or you have like cylinders of air. So they're individual cells rather than one big bladder of air. So you have the air products, the gel products, and the foam. So it's combining those and making your clinical judgment. But every cushion company will tell you theirs is the best. That's the problem. So use your clinical reasoning on that. Okay, sorry, that was a long answer.
No, that's very helpful. And you've spoken about the static air systems. Beyond that, there's the alternating air systems, aren't there? So similar to your alternating air mattresses in hospitals, and they work in a very different way, don't they? It's about having well, as the name suggests, alternating air cells. So you've got pockets of hard air, and in between you've got the air taken out, and they alternate every depends on the system, but sort of 6 to 8 minutes or something like that. So you're actually taking time and then changing those areas. So you never kind of leaving the pressure point in the same place. So they are effective, but also they're not always the most comfortable solution, because you are essentially sitting on a hard cushion. Does that kind of make sense, Joe, what I've explained there?
And of course, the other option, which I haven't gone into because there just isn't time, is like individual custom contoured seating. So that will be specialist foam carve taken from an image in a bag, casting bag, and then that image is taken away and an individual special seat is made. And sometimes people just need that type of seating because their level of postural deformity, postural asymmetry, fixed postural presentation, there's just too much to accommodate with an off-the-shelf product. But they will usually be dealt with, obviously from the NHS or privately from a special seating provider. So.
Brilliant, thank you. I think some of the other questions we've got are relating to the Lento Care Chair that I spoke about. So I'll just cover those off. So we've got a question as to the minimum and maximum width of the armchair. So on the version I showed, which is the adult size version, the seat width goes from 15 inches right the way through to 22 inches. So you've got a lot of adjustment there. But there is a pediatric version of the chair as well, and then there's also a bariatric version too, with a higher weight limit and even wider seat. And in terms of, I've had a question about the cost. The cost tends to be around the 3,000 mark, depending on kind of quantity and what you do to the chair. As I mentioned, they're very much adjustable, and very much you can change your accessories. And we do some special infection control versions, etc., for hospitals too. And then another question, does it come as both manual and powered functions? Great question. Absolutely. The one I showed there was the manual version, but you can have any of the tilt or backrest recline or leg elevation in electric, and you can choose which ones of those you want to be electric, or all three to be electric if you wanted. We had a question, Joe, as to changing the tilt position on a wheelchair or specialist seating um, as a change of position to relieve pressure. So that very much is something that you talked about, isn't it?
Yeah. Yeah. So a change of position doesn't always mean changing from bed to chair. That would be ideal, that somebody comes out of one piece of equipment into another piece of equipment. But without that facility in place, if there isn't a care call and they're waiting for two people to hoist them, you are changing your position when you're tilting, because you're redirecting the loading from your seated surfaces onto your back, and the little movements within that just allow the blood flow, the capillaries, they allow the nutrients, all of that. So don't rule out that as a change of position. So when I say somebody shouldn't stay all day in a chair or all day in a wheelchair, that is true. But if somebody's staying all day in a static chair, I can't do my hands in the right angle, as opposed to in a tilting chair, that is slightly different. Still, we wouldn't ever advocate that somebody stays always in a chair, however good it is. Same with a wheelchair, because our bodies need to change position. They need to ideally sit, stand and lie, but we know many of our users have passed the window of standing. So we need to make sure that our bodies sit and our bodies lie. So if our bodies only ever lie, and that's what happens to many people who are bedbound, who just don't have the care package in place to get them out of bed, they will almost go past the window of sitting, because their bodies are so not used to sitting anymore. And I have this in my private work, and also obviously in my NHS work, when we will go and assess somebody at home for a suitable wheelchair, and they haven't been out of bed for a long, long time. So it's a huge ask then to get this person in an assessment from lying into a wheelchair, because they need to build up their sitting tolerance. So to have let somebody go into a scenario where they've been in bed for 2 years, which is so common, it's not an unusual thing to see, then to have the job to try and get them seated again is really sad. So we need to not let it get to that scenario. We need to stop it before it gets there. You can pass the window with an older person of they've lost their sitting tolerance. It's too difficult to get that back again.
Absolutely, and I think that's it's absolutely key, particularly in sort of a hospital environment. There's a big focus at the moment on preventing deconditioning. So getting someone, or it's called in some areas, and PJ paralysis. So getting people out of the pajamas, out of bed, into a seated position, just because otherwise the rate of deconditioning, the rate of muscle loss really does go up. And then what happens when they're discharged from hospital? Well, they can actually it can be life changing in the wrong way,
Yeah.
to not get someone into a seated position. So something that we're very passionate about. I'm sure everyone on the call is getting people out of bed into a seating position, into a safe position. Um, there's a few more questions, so I probably don't have time to cover them off. I notice we are 1 minute over time. Just some questions as to lifespan for cushions and chairs. Um, on the chairs, you do get a kind of standard warranty on the Lento range, for instance, of 5 years. And all the parts are modular, so you can very much swap parts around. You can replace parts, so that you can keep using the chair. And we've seen these chairs go on for kind of over a decade, with just maybe changing some of the seat cushion or that kind of thing. Interesting question as to lifespan for cushions. Would you have any comments on that,
Yeah,
Joe?
it's a really tricky one. So with the medical devices regulations, it would be that cushions shouldn't ideally be used after 5 years. Um, so, and that's why it's important within NHS organisations and within retail organisations that stock is regularly turned over, that you haven't got a cushion that's sat on the shelf for 3 years. It may still be brand new, but it's 3 years into its life. The foam properties do change over time. So if we're reviewing somebody, we should be thinking there will always be, if it's a medical device, there will always be a serial number that states how old the cushion is. And if somebody you're reviewing is in a cushion that's over 5 years old, you should really be recommending that their cushion is changed. And it might be that it's still really good. So if it's a cushion that's got a firm foam and then an overlay of gel, of air, it could just be that you're changing the component, like the gel or the air. But regular checks, checking that there's no faults, checking that the gel isn't leaking, checking that the air is intact and no little bursts or holes, perforations, and checking that the foam is in good condition. We have to use common sense as well, but the medical devices regulations will say 5 years, but sometimes a cushion can look brand new after 5 years. Sometimes a cushion can look 20 years old after 6 months. We know the different home environments we go into, and hygiene levels really vary from home to home, and individual circumstances really vary with self-care. So common sense always, but on the official answer, it should be 5 years that something should be changed, and you should never be issuing a cushion from stock that's over 5 years old, in a retail or an NHS setting or in a community equipment store setting. So
Yeah, thank you for that. And same with the cushion cover too. It's a very, I think a lot of people kind of forget about cover, but it's a really important part of the cushion. Um, and it can have if you've got a damaged cover or one that's breaking down, even a little crease
yeah,
or any kind of breakdown in the material can have an impact, on that person, because it comes it's very close to the skin, to the human tissue. I notice we are still having some questions come in. I think we probably need to leave it there, but we'll do our best to send some answers afterwards. Thank you so much for joining, everyone. Just as a kind of final thought here, I'm just going to share my screen, and can everyone see that? Can you see that, Joe?
I can see you.
You can see me. Okay. I will just share. Sorry, I've just got.
Just from
Oh,
me,
here we.
thank you for the lovely comments I've read. That really is, yes, really means a lot. In fact, I'm glad it has been useful, and thank you for your attendance. And yeah, the feedback's really, really lovely. Thank you.
Yeah, thank you very much for that. And I just wanted to quickly say, do have a look at our website at www.vivid.care, and there's a resources tab at the top, and there's loads of downloadable resources like specialist seating ebooks, justification templates, prescription forms, seat sizing forms. There's loads of previous webinars, including another one which Joe did a little while ago on posture, which is very helpful, and loads of blogs and different articles. So please do check that out. And if you do have any specialist seating needs or challenges, please do give us a call or email us. There's some contact details there, or you can send us a message through the website. We do one-to-one. We do kind of a lunch and learn training sessions too, and also we can come out and do specialist seating assessments and different demonstrations, etc. So thanks ever so much again for joining. Excellent to have you all on, and thanks to Joe for all your knowledge sharing today. It's been very helpful. Have a lovely rest of your day. Thank you very much.
Thanks, everyone.